Hello friends, I hope you are doing well. MRCPCH clinical examination is just few weeks away. I'm Dr. Sandeepan Paul, your exam guru. Today we will discuss a very important topic for the clinical exam, that is achondroplasia. Please watch the video till the end because a very useful discussion I did at the end. Let's start. Before we start, please like, share and subscribe my channel and don't forget to hype. Achondroplasia is the most common skeletal dysplasia. The prevalence is in between 1 in 20,000 to 1 in 30,000 live births, and it is autosomal dominant condition. This skeletal dysplasia happened due to FGFR3 gene mutation. This gain of function mutation leads to inhibition of endochondral ossification. And 80% cases the mutation is de novo. What is the pathophysiology? This FGFR3 gene mutation leads to defective formation of cartilage in growth plates, which leads to shortened long bone, ended up with rhizomelic dwarfism, which is shortening of the proximal bone. So you can expect shortened arm than the forearm, and the trunk length is normal, and the head is bigger because delayed ossification of the sutures. What are the clinical features? There will be disproportionate short stature. The limb length is shorter, but the trunk length is normal. Frontal bossing and macrocephaly are also associated. And there will be bowing of limbs, lumbar lordosis, and trident hand. What are the complications? These are hydrocephalus due to narrowing of foramen magnum. There could be spinal stenosis, and kyphosis can also be associated. Recurrent otitis media, hearing loss are very common. Sleep apnea is also seen in those patients. And last, obesity. How to make the diagnosis? The clinical phenotype leads to suspicion. Then we need to consider the radiological investigations, which may show shortened long bone with metaphyseal flaring, narrow interpedicular distance in lumbar spine, and genetic test FGFR3 gene mutation. The management of achondroplasia is multidisciplinary. We need to involve the pediatrics, we need to involve the ENT, orthopaedic surgeons, endocrinologist, as well as the neurologist. We need to monitor the patient for the growth and development and neurological features. We need to involve the ENT to prevent the hearing loss and recurrent otitis media. And multiple surgery can also help. The growth hormone has a very limited role, and nowadays vosoritide, which is a CNP analog, are also used. Now we will discuss the prognosis. The intelligence is normal and normal life expectancy with proper management. There is a risk of cardiovascular disease as well as obesity, and we need to take care of the psychological development. The key takeaway message. This is common skeletal dysplasia, which happened due to FGFR3 gene mutation, leads to disproportionate short stature with characteristic facial features. And the management is multidisciplinary. Now we will discuss the clinical cases we expect in our examination. Please pay attention to the opening statement. If the opening statement is saying this is your case, do the examination of the system that you feel appropriate. Then you need to start the short stature approach, that is move, measures and maneuver. Check out my short stature video for the detailed examination. Then you need to comment on the musculoskeletal examination finding as well as the other systemic examination finding, including the Brighton score. If you have been told this patient is having the difficulty in walking, and do the examination of musculoskeletal system, then you need to start with the Pegel's lower limb, and then you have to do the examination of joint of the lower limb, that is look, feel, move. And please check out my MSK examination for the details. And the third case scenario, if you have been told this patient is having pain in joints and do the musculoskeletal examination, then you need to start with the Pegel's. Don't forget, Pegel's is a screening examination. Once you find the joint is involved, you have to do look, feel, move, that maneuver for the joint examination, and one joint above and one joint below. I hope it clarifies a lot of your confusion what is to be done in examination. But if you have any confusion, always ask the examiner. I hope this video was useful to you. Please like, share and subscribe, and don't forget to hype. See you in next video. Thank you.